Dear viewers, this is the beginning of part 2 in the three-part series on tobacco-related diseases in the Prescribon Medical Education series. Currently, free radical mediated oxidative stress is emerging as the pivotal step for the development of atherosclerosis. For cigarette smokers, free radicals could arise from 1. The gas or tar phase of cigarette smoke. 2. Circulating or on-site activated macrophages and neutrophils. And 3. Endogenous sources of reactive oxygen species, ROS, such as uncoupled endothelial-mediated nitrous oxide synthase, xanthine oxidase, and the mitochondrial electron transport chain. A reaction between free radicals such as superoxide and nitric oxide not only decreases nitric oxide availability but also generates peroxynitrite, which further enhances the cellular oxidative stress. Increased oxidative stress with the loss of the protective effect of nitric oxide tips the cellular balance towards a pro-atherogenic and pro-thrombotic milieu. Many of the abnormalities described above, including endothelial dysfunction, pro-inflammatory effects on the vessel wall, prothrombotic effects such as increased platelet reactivity, reduced endogenous fibrinolysis, and lipid peroxidation, can largely be explained by the effects of increased oxidative stress. Furthermore, antioxidants or agents that reduced the oxidative stress or increased nitric oxide availability have been shown to either improve or reverse the pro-atherogenic, pro-inflammatory, and pro-thrombotic attributes associated with cigarette smoke. Conduction abnormalities in heart due to smoking. Smoking is associated with cardiac arrhythmia, stroke, heart failure, and sudden cardiac arrest, all of which may derive from increased sympathetic influence on cardiac conduction system and altered ventricular repolarization. This picture shows a normal bronchus and a bronchus in chronic bronchitis. The normal bronchus has a broad lumen, but in chronic bronchitis, the lumen is narrowed, inflammation is present, the smooth muscle is thickened, and there is excess mucus glands. The normal alveolar sac has plenty of alveoli. In diseases such as emphysema, destruction of alveolar walls decrease the surface area of alveolar walls, decreasing the area available for gas exchange. Lungs. See figure normal bronchus and chronic bronchitis described just now. Also the figure normal alveoli and the alveoli in emphysema. Chronic obstructive pulmonary disease (COPD) is characterized by poorly reversible airflow obstruction and an abnormal inflammatory response in the lungs. The latter represents the innate and adaptive immune response to long-term exposure to noxious particles and gases, particularly cigarette smoke. All cigarette smokers have some inflammation in their lungs, but those who develop COPD have an enhanced or abnormal inflammatory response to inhaling toxic agents. This amplified response may result in mucus hypersecretion, that is chronic bronchitis, tissue destruction as in emphysema, and disruption of normal repair and defense mechanisms causing small airway inflammation and fibrosis as in bronchiolitis. These pathological changes result in increased resistance to airflow in the small conducting airways, increased compliance of the lungs, air trapping, and progressive airflow obstruction, all characteristic features of COPD. Dear viewers, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Pathogenesis. Inflammation is present in the lungs, particularly the small airways of all people who smoke. This normal protective response to the inhaled toxins is amplified in COPD, leading to tissue destruction, impairment of the defense mechanisms that limit such destruction, and disruption of the repair mechanisms. In general, the inflammatory and structural changes in the airways increases with disease severity and persist even after smoking cessation. Besides inflammation, two other processes are involved in the pathogenesis of COPD: an imbalance between proteases and antiproteases, and an imbalance between oxidants and antioxidants, that is, oxidative stress in the lungs. Inflammatory cells. COPD is characterized by increased numbers of neutrophils. In general, the extent of the inflammation is related to the degree of the airflow obstruction. These inflammatory cells release a variety of cytokines and mediators that participate in the disease process. Oxidative stress. The oxidative burden is increased in COPD. Sources of oxidants include cigarette smoke and reactive oxygen and nitrogen species released from inflammatory cells. This creates an imbalance in oxidants and antioxidants of oxidative stress. Pathophysiology. The above pathogenic mechanisms result in the pathological changes found in COPD. These in turn result in physiological abnormalities, that is, mucus hypersecretion and ciliary dysfunction, airflow obstruction and hyperinflation, gas exchange abnormalities, pulmonary hypertension, and systemic, that is, whole body effects. Mucus hypersecretion and ciliary dysfunction. Mucus hypersecretion results in a chronic productive cough. This is characteristic of chronic bronchitis, but not necessarily associated with airflow obstruction. Not all patients with COPD have symptomatic mucus hypersecretion. The hypersecretion is due to squamous metaplasia, increased numbers of goblet cells, that is, mucus producing cells, and increased size of bronchial submucosal glands in response to chronic irritation by noxious particles and gases. Ciliary dysfunction is due to squamous metaplasia of epithelial cells and results in difficulty in expectorating. Note: the respiratory epithelium is composed broadly of 4 cell types: basal cells, ciliated cells, secretory cells, and intermediate cells. Abnormal epithelial remodeling occurs in COPD with common changes, including goblet cell metaplasia, basal cell hyperplasia, and squamous metaplasia. These changes are more frequent in COPD. Cigarette smoking causes aberrant repair processes. Airflow obstruction and hyperinflation or air trapping. The main site of airflow obstruction occurs in the small conducting airways that are less than 2 mm in diameter. This is because of inflammation and narrowing and inflammatory exudates in the small airways. Other factors contributing to airflow obstruction include loss of the lung elastic recoil due to destruction of alveolar walls. The airway obstruction progressively traps air during expiration, resulting in hyperinflation at rest. Hyperinflation reduces the inspiratory capacity and therefore the functional residual capacity during exercise. These features result in breathlessness and limited exercise capacity typical of COPD. Gas exchange abnormalities. These occur in advanced disease and are characterized by arterial hypoxemia, that is decreased oxygen, with or without hypercapnia, that is increase in partial pressure of carbon dioxide. Usually partial pressure of carbon dioxide is 38 to 42 millimeters. In COPD it is 45 millimeters. Pulmonary hypertension. Structural changes in the pulmonary arterioles result in persistent pulmonary hypertension, that is increased blood pressure in pulmonary circulation, and right ventricular hypertrophy or enlargement and dysfunction, that is pulmonary. Systemic effects of COPD. Cachexia, that is weakness, general weakness, skeletal muscle wasting and disuse atrophy, increased risk of cardiovascular disease, normochromic normocytic anemia, a type of anemia, osteoporosis. Pathophysiology of exacerbations. Exacerbations, that is increase in severity of disease, are often associated with increased neutrophilic inflammation and in some mild exacerbations, increased number of eosinophils. Exacerbations can be caused by infection, that is bacterial or viral, air pollution, and changes in ambient temperature. In mild exacerbations, airflow obstruction is unchanged or only slightly increased. Cerebrovascular system. Impact of cigarette smoke exposure on the cerebrovascular system. Recent evidence has indicated that active and passive cigarette smoking are associated with dysfunction of normal endothelial physiology. There is strong evidence for an association between smoking and vascular impairment. Similarly, there is a strong impact of tobacco smoke exposure on the blood-brain barrier, BBB. This is a major problem given that the blood-brain barrier is crucial in the maintenance of brain homeostasis. Chronic smokers have a higher incidence of small vessel ischemic disease, that is SVID, a pathological condition characterized by leaky brain microvessels and loss of blood-brain barrier integrity. In the brain, tobacco smoke increases the risk of silent cerebral infarction, SCI, and stroke owing to the procoagulant and atherogenic effects of smoking. Tobacco smoke induces oxidative injury to the cerebrovascular system. Oxidative stress is induced by reactive oxygen species, ROS, which are either free oxygen radicals or reactive anions containing oxygen atoms. These highly reactive species can then interact with molecules containing oxygen atoms and propagate the production of other free radicals. Unfortunately, tobacco smoke contains very high levels of superoxide and other reactive oxygen species derived from cigarette combustion. Therefore, the vascular adverse effects of smoking can be the result of endothelial exposure to reactive oxygen species. Damage to cells occurs as a result of ROS-induced alterations of macromolecules. This includes lipoperoxidation of polyunsaturated fatty acids in membrane lipids, protein oxidation, DNA strand breakage, RNA oxidation, and mitochondrial depolarization and apoptosis. Mutations of the nuclear protein p53 leading to apoptosis are also associated with tobacco smoke toxicity. Antioxidant supplementation prevents, to some extent, the oxidative damage and inflammation induced by cigarette smoke exposure. Thus, strongly supporting the hypothesis of a ROS-mediated toxicity of tobacco smoke exposure. Tobacco smoke induces inflammatory and thrombotic injury. Components of cigarette smoke also contribute to a pro-atherosclerotic environment by triggering a complex pro-inflammatory response through the recruitment of leukocytes to the site of inflammation and by promoting the adhesion and binding of monocytes to the endothelial wall of blood vessels. Inflammatory activation of endothelial cells promotes the adherence of monocytes to vessel walls. Elevated levels of white blood cells, primarily neutrophils and monocytes, are observed in smokers. In particular, neutrophils secrete free radicals, elastase and collagenase, which are thought to contribute directly to endothelial cell injury, and they add to the immune response. Despite the fact that smoking triggers significant pro-inflammatory activity, and active smokers therefore have significantly higher number of circulating white blood cells, they are generally more susceptible to viral and bacterial inflammatory neuropathologies than non-smokers. This suggests that chronic smoking undermines the ability of the host immune system to counteract viral and bacterial infections. Smoking compromises the effect on the blood-brain barrier integrity and can facilitate the pathogenesis of neurological disorders such as bacterial and viral meningitis. Smokers are also reported to be at increased risk for thrombosis. Platelet activation is frequently observed in smokers in response to increased levels of platelet activating factor, von Willebrand factor, catecholamines, and thromboxane. All these factors pose a serious threat at the level of brain microvasculature, where vascular tone regulatory mechanisms are absent. Pathophysiology of endothelial cells. The blood-brain barrier has been shown to maintain brain homeostasis. It selectively excludes most endogenous and xenobiotic blood-borne substances from entering the brain, protecting it from systemic and exogenous influences. Note: xenobiotic is a term used to describe chemical substances that are foreign to animal life and thus includes such examples as plant constituents, drugs, pesticides, cosmetics, flavorings, fragrances, food additives, industrial chemicals, and environmental pollutants. Dysfunction of the blood-brain barrier is involved in the pathogenesis and progression of a number of neurological disorders, including stroke, multiple sclerosis, Alzheimer's disease, dementia, epilepsy, etc. A stroke, sometimes called a brain attack, occurs when something blocks blood supply to part of the brain or when a blood vessel in the brain bursts. In either case, parts of the brain become damaged or die. A stroke can cause lasting brain damage, long-term disability, or even death. Multiple sclerosis (MS) is caused by the immune system mistakenly attacking the brain and nerves. In multiple sclerosis, nerve damage results in disrupting communication between the brain and the body. Multiple sclerosis causes many different syndromes, including vision loss, pain, fatigue, and impaired coordination. Alzheimer's disease is a progressive neurological disorder that causes the brain to shrink, that is, atrophy, and brain cells to die. Alzheimer's disease is the most common cause of dementia, a continuous decline in thinking, behavioral, and social skills that affects a person's ability to function independently. Dementia. This is a term used to describe a group of symptoms affecting memory, thinking, and social abilities severely enough to interfere with your daily life. Cigarette smoke leads to cerebrovascular dilatation through sympathetic activation. Nicotine activates nicotine receptors, which leads to the acetylcholine dependent release of nitric oxide from the vascular endothelium through activation of endothelial nitric oxide synthase. Nitric oxide is one of the major endothelium derived relaxing factors, which plays an active role in regulating microvascular tone and the cerebral blood flow under normal and pathological conditions. Nitric oxide has been shown to increase vascular permeability at the blood-brain barrier, thus impairing brain homeostasis and facilitating the passage of untoward substances from the blood into the brain. Dear viewers, this is the end of part 2 on this 3-part series on tobacco-related diseases. You can view the other videos in Prescribon Medical Education series, Tobacco-related diseases. Thank you for viewing the videos.